Hi, everyone. Welcome to our 2021 Care-Based Incentives Workshop webinar. My name is Jo Peary. I'm a Quality Improvement Coordinator at Central California Alliance for Health. And on behalf of everyone here, thank you all for taking your time and joining us this afternoon. Before we get started, just a few housekeeping items to address. Today we are using GoToWebinar, which defaults to your computer's speaker system for audio. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You may then use that information to call in from your phone. We highly encourage you to ask questions throughout this webinar and ask only that you submit them by using the questions pane on the control panel also. We will collect the questions submitted and have our presenters address them during the Q&A session at the end of the webinar today. Handouts were sent to you this morning, and they are also available in the handouts pane as well. So feel free to grab those at your convenience if you need them. Many of you know Oscar Sanchez, and today he will be your contact for any technical issues you may experience. His email address is osanchez@ccah-alliance.org. It's at the bottom of the slide also, and I'll give you just a moment to jot it down. Here are our presenters today. Kristen Presley is a Quality Improvement Program Advisor at the Alliance. She has over 6 years of Medi-Cal managed care experience working on quality improvement and population health projects. Kristen brings research experience in decision-making and patient trust from UT Health Medical and Biomedical Informatics School and MD Anderson Cancer Center. Dr. Diana Diallo is our newest medical director, joining the Alliance this past April. Before joining our team, Dr. Diallo spent almost 12 years serving the children of Monterey County. She was most recently with Monterey County Clinic Services. With more than 12 years of healthcare experience, we have Sarah Forbes, our Quality Improvement Coordinator. Sarah has been with the Alliance for 5 years, working with our Provider Services team, and then joining our Quality Improvement Department. She is passionate about our CBI program, has piloted our practice coaching initiatives, and enjoys working with our providers to improve their aspects of care. And without further ado, I will hand this off to Kristen.
Thank you, Jo. So this year's presentation is similar in structure to the agenda of past workshops, where we will cover an overview of the CBI program structure, new measures for 2021, modified measures. We will also have a message on preventive care from Dr. Diallo. We'll then be going into exploratory measures, retired measures, and resources from the Alliance to help your practice. So let's begin with the program overview. Since 2010, the Alliance Care-Based Incentive Program has encouraged primary care physicians to adopt and implement the patient-centered medical home model. As part of the Alliance's strategic plan, CBI aligns under the promotion of value, offering an upside risk, value-based payment to primary care providers to promote better healthcare outcomes, improved access to care, and promotes the delivery of high-value care. Goals for the 2021 program include improved quality outcomes aligned with the CMS core measure set for adults and children, the National Committee for Quality Assurance, NCQA, for their healthcare effectiveness and data information set, which is also known as HEDIS. And goals also include encouraged adoption of best practices as recommended by the United States Preventive Services Task Force, testing measures as exploratory to allow for observation, as well as reflection as a best fit within our network goals, and last but not least, improved patient access and utilization of primary care, which includes state-focused gaps in preventive services, such as monitoring and screening of lead poisoning in children, as well as reducing disparities in quality of service delivery between groups of members and/or geographic regions. As a program, CDI is split into two different measure types. So the first one is fee-for-service, and it is a single payment. So it's a per service, per payment measure type. So there's no rate calculation, no eligible denominator population, but it's just a paid measure at that service level. So for the programmatic measures, this is something where we look at quarterly performance throughout the year, and then it ends with a payment annually after the end of quarter 4. Payment is based at the CDI group level, looking at the rate, and it will end in the rolling 12-month measurement period from the calendar year of January to December. And then one thing that I did want to note is that if there are any staff that are new to CDI and it would benefit for them to learn more, please reach out to your provider relations representative to schedule a training. So the programmatic measures are divided into a total of 100 points. So this grid allows you to visually see the point allocation for each measure. To accommodate for the new addition of application of dental fluoride, we've adjusted the preventable emergency visit measure from 15 to 12 points to add 2 points to the application of fluoride varnish. In addition, we also added 1 point to the previously named alcohol misuse screen and counseling, now named unhealthy alcohol use, to accommodate for the addition of adolescents, which we will be going over in the later slides. The points of the quality of care measures will still stay the same, just with a new distribution amongst the measures when we either add or remove measures from the measure set. And so here on the screen, what you can see is the body mass index assessment adults has been removed. So following on to the second page, you can see the new child and adolescent well-care visit measure in the quality of care measure set, as well as the same performance target points of 10. So the CDI timeline was added to the CDI incentive summary for the first time last year and has since been updated to reflect the rolling quarters for the CDI 2021 program year. So this again is another visualization where you can look at eligibility as well as the payment periods for the programmatic and fee-for-service measures. As you can see in the top left bars in gray, those are last year's CDI 2020 measurements for programmatic eligibility as well as the payment period, matching the 2020 calendar year. Followed in blue are the CDI 2021 quarters, which move left to right from quarter 1 to quarter 4, ending with the calendar year 2020 for the programmatic payment as well as the quarter 4 fee-for-service payment period. So the billing period is a little bit different from what you see here for quarter 4, and that's consistent with our previous program years for CDI, but we do allow for a little bit of additional time for claims as well as data submissions that Sarah will be going over in the later slides. So before we get into new measures, we wanted to take this time to recognize the top 3 performers in Santa Cruz, Monterey, and Merced County. These practices were selected based on the total CDI programmatic points that they received in 2019 and combines all of the comparison groups together. So thank you again to these providers for leading the way in your region. So next, we will discuss what's new in the program. Application of fluoride varnish is a measure that we introduced as exploratory for the 2020 program. This measure looks at the percentage of your members aged 6 months to the age of 5 who have received at least 1 topical application of fluoride varnish. This measure is important because for children, dental caries is one of the most common chronic childhood diseases that is largely preventable. When left untreated, dental caries can also lead to extensive treatment under general anesthesia, but early stages of dental caries can be reversed or slowed with appropriate oral hygiene, as well as through preventive measures like fluoride varnish application. So during the pandemic, providers have experienced additional challenges to care, and likewise for members, disruptions to routine oral health maintenance at well-child visits, dental appointments, and school-based oral health programs. The nice thing about fluoride varnish is that it does limit the risk of aerolization, which is found in dental cleanings and is a safer preventive step for both the healthcare worker as well as the patient to reduce dental caries. For more information on training, please contact your local CHDP office for more information. So the Child and Adolescent WellCare Visit is a new measure from NCQA, which combines the old well-child visit, 3 to 6 years of age, as well as the well-adolescent visit, 12 to 21 years of age. But it also adds in this missing gap range of 7 to 11-year-olds who were previously not recorded. So this is great because it does create a comprehensive visit, which then includes all of the age ranges when we're looking at the child and adolescent population. And so this measure looks at the same comprehensive WellCare visit codes with a PCP or an OBGYN within the measurement year. One thing to note is that for the billing frequencies, these change with age. So for the 3 to 17-year-olds, well visits are payable every 180 days. And for the 18 to 21-year-olds, well visits are payable once every 12 months. Similarly, for our younger well-child measure, for members that are 0 to 24 months, well-child visits are payable every 14 days. The Plan All-Cause Readmission Measure is an NCQA HEDIS measure that will replace the 30-day readmission measure that we had in last year's program. So this measure looks at the number of acute inpatient observation stays that results in an unplanned acute readmission within 30 days. One noticeable difference is that the age group now starts at 18 years of age, and the measure will be reflective as a rate rather than the previous PKPY or per 1,000 member per year calculation. There are similar exclusions, such as hospital exclusions for the diagnosis of pregnancy or perinatal stays. In addition, there are also planned admissions like chemotherapy, rehabilitation, kidney, organ, and bone marrow transplants. New to the exclusion list is if a member expired during the stay or if the planned admission is a potentially planned procedure, such as a coronary artery bypass or surgery for things like drainage, extraction, removals, or repairs. For our next measure, as I mentioned earlier, the new naming convention from the United States Preventive Services Task Force is to adopt the term unhealthy alcohol use, which will replace the alcohol misuse screening and counseling, and now also includes the addition of the adolescent population. So this measure will review whether members 11 years and older who are screened for unhealthy alcohol use in primary care settings, in addition to providing behavioral counseling interventions to those that are 18 years and older. So one thing to note about the billing is that for the HCPCS G code G0442, this code is billable for Alliance members 11 years and older. However, the two LOIN codes that you see, in addition to the counseling code G0443, is only applicable to be billed for members that are 18 years and older. So one of the interesting outcomes of the pandemic is the push for increased access to telehealth visits. So the type of telehealth visit is broken down into two distinct categories, so either synchronous or asynchronous telehealth. And so synchronous does require a real-time interactive visit with the member. So this could be through the telephone, or it could be through a video telecommunications. And then asynchronous telehealth is a not real time, which is something that could be made through the patient portal, secure text messaging, or email. For our purposes, Medi-Cal guidelines utilize the notation of the telehealth modifier and or telehealth point of service code, depending on whether you bill with the CMS 1500 form or the UB04 form. NCQA has removed or expanded the use of telehealth visits, which is great because it does positively impact the different measures that we look at. So one of the exclusions that they previously had was to not include telehealth visits for well visits. It's now allowed, in addition to the use of telehealth visits in capturing different diagnoses of chronic conditions. So in the table that you see below, you could have a telehealth visit where you could capture the diagnosis of major depression, which would fall under the antidepressant medication management measure, or asthma, diabetes, high blood pressure. In addition, for our maternity care measure for prenatal, they also accept telehealth visits for one of the prenatal visits. So that's another great addition from NCQA. Another change to the CBI 2021 program is the introduction of the CBI payment adjustment. The managed care plans are now seeing an increasing pressure to meet with their new minimum performance levels, and CBI was designed to be above that threshold. However, the bar has been raised from the 25th to the 50th percentile for Medicaid plans. What that means to the Alliance is that failing to meet the minimum performance levels could require us to complete a Plan Do Study Act cycle with a provider partner, which is one of those rapid cycle projects, typically in the lines of 3 months. In addition, we could also be assigned a corrective action plan or sanctioned, including financial penalties. As such, the CBI 2021 program will be implementing a payment adjustment following the finalization of the quality of care measure results. And these measures in particular can be met through either telehealth or in-person visits. The points associated with the quality of care measures will remain the same, starting to accrue CBI points when you are above the 50th percentile, and then it moves up from there. So the 75th to the 90th range, you get 75 points for those measures, and then the 90th percentile, you will receive the full CBI points that are allocated to those measures. The following tier system will be applied to the payment adjustment. And so for tier 1, what we're looking at is 1 to 3 measures that are between the 25th and the 50th, and no measures that are below the 25th. The programmatic payment will be adjusted to 75% of what the total would have been. In tier 2, if you had 4 or more metrics between the 25th and the 50th percentile and no metrics below the 25th, then the programmatic total would be cut in half for the payment. In tier 3, if you have 1 to 3 metrics that are below the 25th, then the programmatic total will be at 25% of what the payment would have been. And then if you have 4 or more metrics below the 25th percentile, then it will result in no payment for CBI. In addition, if you have those 4 or more metrics that are below the 25th, you will also be issued a corrective action plan. As part of our strategy to have more readily available information, we do hope to share with you similar mid-year performance reports in the future. And so this report was created in July, allowing for an earlier look at the Q2 performance rates that ended just the month before. And so this would be something where you could take a look at your quality of care rates, see where you are halfway through the year, and then still have the end have the next 6 months to kind of correct anything or make any workflow changes to try to improve those rates. Another resource that's available to all providers is the opportunity to participate in our practice coaching program. And so our practice coaches will work with your office to assess as well as help you implement your quality improvement plan or project. So this is another resource that's available by the Alliance that Sarah will be covering in detail in the future slides. So now that we've covered the program itself for the new measures, we're going to shift our focus to the modified measures. And so these are measures that you are likely very familiar with us from our years past, but we've made a couple of changes to them. So the preventable emergency visits has been modified to reduce the points taken account for urgent visits. So preventable emergency visits that are showing at the urgent visits will now count as half the value as when you have a patient arrive at the emergency department. And the reason for that was just to kind of provide value. So in terms of the level of care and the resources that are devoted to urgent visits, we did want to recognize that that is a better low level of care for the patient than going to the emergency department. And so that's the reason why we wanted to make sure to cut the points in half for that. As part of the best practices, we do like to advocate and have your office advocate for the use of the Alliance's nurse advice line. The phone number is located on this slide, but basically our nurse advice line is available to all Alliance members 24 hours a day, 7 days a week. So anytime that they wanted to call, this would be a great resource in terms of discussing their concerns and then seeing where would be the best place to go, whether their advice is to go see the PCP that day or see them within the week. The other thing in terms of education that we like to promote is letting our members know what your office resources are. So whether you have same-day appointments, after hours, or weekend visits, just making sure that they also know when your schedule availability is so that they make that initiative to call your office first before they go out to an urgent visit or the ED. In terms of reports, we have a number of different reports on the provider portal, but specific to emergency department visits, we do have a portal report that's updated daily. So if you were to go to the provider portal linked member ED visit, this would let you know which providers that are linked to your office have gone in to see an emergency department, and then what was the chief's complaint for that. In addition, we also have a high utilizer report that will let you know if you had a member of yours that went in 3 or more times to the emergency department within the last 90 days. So this is another great resource just in terms of identifying those patients. They may be patients that you're also very familiar with, but if there's someone that is new, that's a new opportunity for you to educate them and have them brought into your office. So next, I would like to introduce and hand the slides off to Dr. Diallo, who will be going into detail our new era of preventive care.
Hello, everybody. So with COVID and shelter in place and appropriate fears around it, there's been a dramatic reduction in preventive care visits for children. So there's a number of reasons for that. Some of it is fear-based, fear of children getting sick, fear of bringing something home to a higher risk family member. There's the fact that offices have restricted in-person access. But the numbers that are given around this, reported by Fair Health, a nonprofit organization that manages a database of 31 million medical claims, reported a 52% drop in March of 2020 in preventive care visits and a 58% drop in April of 2020. You can also see this through the Vaccine for Children program that reported a reduction of 2.5 million fewer doses of vaccines were ordered in mid-March to mid-April of 2020. And both of those statistics were reported in the Pediatric News from August of 2020. There's also been a noted immunization rate drop of 40% after the shelter-in-place order. Next slide, please. So you can see what our local statistics are here. We look down at the bottom, we see the national average for vaccination rates is 35.4% of 2-year-olds are up to date and 35.3% of 13-year-olds are up to date. When we compare that to our 3 counties, we see that Monterey County is at 52.85% of 2-year-olds and 62% of 13-year-olds being up to date. Santa Cruz is fairly comparable at 50.14% of 2-year-olds and 56.64% of 13-year-olds. In general, all of our counties are doing quite well in the 13-year-olds. Merced County has 19.44% of 2-year-olds up to date and 38.84% of 13-year-olds. Next slide, please. So one of the consequences of shelter in place has been an increased reported injuries in children, unfortunately. Some of that is due to increased parental stress, financial, social isolation, lack of adequate child care. Some of it's from decreased supervision, as many parents are trying to work from home while their children are there. There's also data around increased severe physical abuse. It's being identified in emergency departments and identified probably later than it normally would have been because children are not in contact with the mandated reporters they would normally see in doctor's offices, at school, etc. In fact, Children's Hospital in Colorado saw a 118% increase in overall trauma with a 200% increase in non-accidental trauma between January and April of 2020. In addition, there's a CDC survey from June of 2020 that showed 25.5% of young adults aged 18 to 24 reported seriously considering suicide in the previous 30 days. This is just a high stress. It's been a very, very high stress time for everybody, but particularly our kids and young adults and the parents of the kids and young adults. Next slide, please. So I think you all are pretty familiar with the important role of preventive care for children, but we'll go through it. Vaccines to avoid vaccine-preventable illnesses. And preventive care visits, we monitor the health and safety of children, monitor their growth and development. We do screenings such as lead, TB, anemia screenings. We address the social determinants of health and really try to help connect families with supportive services. And right now that's especially critical with dramatic increases in mental health issues. Just here at the Alliance, we've noticed a lot of increase in eating disorders in adolescents and young adults. And this is anecdotally, I heard from a friend about a local school board meeting that parents were concerned that their elementary school age children were crying every day with the remote learning. There's just so much stress and anxiety today in that social isolation is feeding. Next slide, please. So the importance of preventive care for adults. Detect and prevent hidden illnesses early, such as the cancer screenings, monitor blood pressure. maintain optimal health, such as keeping track of weight, lifestyle, social determinants of health, making appropriate referrals for mental health, vaccinations to prevent vaccine-preventable illnesses, management of chronic disease, which untreated may lead to much more concerning health consequences, such as asthma and diabetes, et cetera. I was talking to a couple of local intensivists, one of which their ICU was hit fairly hard with COVID-related illnesses, but the other of which this summer was not hit particularly hard with COVID, but they were very busy, more because of complications from delayed care and people who waited too long to come in, and so therefore were much more sick than they would have otherwise been, ended up in the ICU. Next slide, please. So all of this is to say it's past time to resume care. We're encouraging our members to contact their PCP to get back to their preventive care visits. Telehealth options are available in many offices. This can reduce in-person contact time. We're encouraging members to call their PCP offices and ask what precautions for COVID-19 are put in place in order to help everyone feel a little bit more comfortable. And most importantly, keep up all the very important work that you each do every day. I'm now going to pass this on to Sarah Forbes to discuss new exploratory measures for CBI.
Thank you, Dr. Diallo. Hi, everybody. My name is Sarah. As Joe mentioned in the beginning of our presentation today, I'm a Quality Improvement Coordinator at the Alliance, and I will be closing out our presentation with the last 3 agenda items for today. So first and foremost, I'm just going to review the exploratory measures that we've implemented into the CBI program for 2021. So for those of you familiar with the CBI program, this will be a reminder, but those of you new to CBI, I just wanted to reiterate that exploratory measures do not qualify for payment. We do track your rates, and you are able to see those rates on your practice profiles. We will also have the data available to you on a quarterly basis so you can track your members' compliance throughout 2021. So the next 2 measures that we've implemented are exploratory. So let's go ahead and review those. The first exploratory measure is called tuberculosis or TB risk assessment. And for this measure, we are looking at the percentage of members ages 12 months to 21 years, so up to the member's 21st birthday, who have been screened. And I really want to emphasize the word screened, and you'll hear me say that in the next few slides quite a few times. So we're looking for those who have been screened for tuberculosis risk factors by staff at the office during the measurement year. We want to make sure that our members are being screened for risk factors, and only those with positive risk factors are being tested. So in previous years, we tested often without establishing a risk for disease, and now we're asking for screening to be completed. If the answers are negative, then there is no need to proceed for the test. However, if a member screens positive, then a TB testing is required so we can treat and stop the spread of disease. And I will go over more of this in the upcoming slides. But first and foremost, this measure is the first line of defense against tuberculosis and is a part of the Bright Futures recommendations. We're looking for the screening of children because they tend to progress faster from infection to active TB and are more likely to have a life-threatening form of disease like TB meningitis. The reason that we care so much about this measure is because we're working towards eliminating tuberculosis from California. And the most common cause of active TB in California now are persons that had LTBI or latent tuberculosis infection for many years without any treatment. After many years of having LTBI, adults often develop other chronic conditions that break down their immunity, so allowing TB germs to multiply and then spread. We can prevent active TB cases by screening all patients and finding and treating people with latent tuberculosis infection. 80% of TB disease in California comes from the progression of untreated LTBI. As most of you know, TB is transmitted through the air, infects the lungs, but it can also spread to other organs, bones, the brain, and other tissues. Tuberculosis, or TB, is caused by a bacterium called Mycobacterium tuberculosis. People can develop conditions that will heighten the risk of TB, and those will need to be treated first. The bacteria are known for attacking the lungs, but it can also attack any part of the body, such as the kidneys, spine, and even the brain. Not everyone infected with TB bacteria will become sick. So as a result of that, two TB-related conditions exist: latent TB infection, or LTBI, and TB disease. Over 11 million people are estimated to have LTBI, and just 5 to 10% will develop TB disease if untreated. You want to treat tuberculosis infection in a timely manner, because if you don't, the immune system can break down the pods in the lungs that harbor this disease. They can then open up, make you ill, and then contagious. So if you can treat TB sooner than later, then only few will actually become infected. We added this measure because the majority of active cases of tuberculosis are from people that were infected and even possibly tested, but never treated. So I'm going to define the word screening, and I know I've said that a few times today, so this is a rather detailed explanation or definition of screening, but I'm going to break it down just a little farther. Screening is defined as the presumptive identification of unrecognized disease in an apparently healthy asymptomatic population by means of tests, examinations, or other procedures that can be applied rapidly and easily to the targeted population. So that was a really long definition of the word screening. I'm going to break it down and simplify. Screening can be a confusing word in the medical sense because we use it to describe both a survey or a collection of data, or it could even mean a type of test of someone that is otherwise asymptomatic. So for example, a pap smear. In TBI world, we call that a cervical cancer screening. But for this measure, we're talking about a screening or survey, not an actual test. We're talking about healthy kids that receive a screening for tuberculosis. If the screening is negative with no risk factors, then that's fantastic. If the screening results are positive, then TB testing should then be completed. Of course, you will have those individuals that need the testing for either their job or any other extenuating circumstances. And of course, in that case, when they come to your office, the testing can be completed. So I hope that you're familiar with the risk assessment form that's on the left-hand side of your screen. It's about 2 pages. It comes with additional resources for both adults and children. On the right-hand side of your screen is the process or workflow for primary care providers. This document has the California Department of Public Health seal. I highly recommend printing this out for your office to use as a reference. For this measure, I'd like to emphasize steps 1 and 2. So on the right-hand side of your screen, first and foremost, we want to identify those patients who are at risk for TB infection, and then we want to test. So if the test is negative, then you're good to go. If the test is indeterminate, then it needs to be repeated. And lastly, if it's positive, then you need to screen for tuberculosis. Of course, I know you know this, always document and then go on to the testing. If your clinic needs additional resources or training, I would like to refer you back to the Alliance's web module. We do have a module on the provider webpage, or you can ask your provider representative for more information, and one of us would be happy to help. Those who should be assessed for tuberculosis include infants and children, members coming from countries where TB is more common. If a member presents him or herself after spending time with someone who is tested positive with TB disease, and of course, those living in confined spaces or close quarters such as homeless shelters. With the hope of eliminating tuberculosis in the United States, this requires expanding testing and treatment of LTBI. So we're starting by focusing on children and measuring network adherence to TB screening. In order to give perspective on how many screenings are currently being performed in each county includes Santa Cruz, Monterey, and Merced, we've provided data that includes the rates and a breakdown of each age group. When we looked at the data, we can see that Merced is doing really well with screening, but we do want to continue to increase these rates for all three of our counties. As a reminder, the screening intervals are located on the Bright Future schedule and should be incorporated into your office if it hasn't already. So now what about schools? So I do know that most of schools are currently closed, as Dr. Diallo was just mentioned in her section. However, I do live in Merced, and I've heard talk that our schools should be opening, or will be, some of them, opening in the next 2 weeks or so. So we included this because according to DHCS, a TB risk assessment or screening is required for students. The TB testing is only required if the assessment indicates a risk for TB. So please don't test if there isn't a risk. Reminder, this is actually a state form and should be completed for students, the screening, not the test itself. The website where you can view this form is listed on the screen. For more information, please let us know, and we'd be happy to send this information or resource over to you. So now on to the second exploratory measure that we have for 2021. So that was it for TB. Now we're moving on to lead screening in children. For this measure, we're looking at the percentage of children 2 years of age who had one or more capillary or venous lead blood tests for lead poisoning by their second birthday. Our recommendation is to identify every child without a record of completing the blood lead screening test and provide the oral or written guidance to a parent or guardian relating to risk of childhood lead poisoning. We are currently working on a quality report for providers as well, so you will be able to have the opportunity to pull that list. Some reasons to check for lead levels. What are those? So number one, exposure to lead in children can cause damage to the brain and other vital organs, as well as intellectual and behavioral deficits. Research suggests that there is no safe blood lead level and its effects are irreversible. Children exposed to lead have no obvious symptoms, and as such, lead poisoning often goes unrecognized. Elevated blood levels primarily affect children with a lower socioeconomic status and from minority communities because of the increased risk of housing-related exposure. Even low levels of lead exposure have lasting neurodevelopmental effects. Since lead exposure at low levels that do harm may not cause symptoms, at-risk children may not be identified and therefore would not receive appropriate treatment or environmental investigation. A January 2020 report by the Auditor of the State of California determined that millions of children in Medi-Cal are not receiving lead testing, and that CDPH is not prioritizing the prevention of lead poisoning. Federal law requires states to screen children enrolled in Medicaid for elevated blood lead levels, or BLLs, as part of required prevention services offered through the Early and Periodic Screening, Diagnosis, and Treatment, or EPSDT program. State regulations impose specific responsibilities on doctors, nurse practitioners, and physician assistants doing periodic healthcare assessments on children. There is a lead screening webinar coming up next week. Actually, it is a week from today at noon. It is from 12 to 1:30, being held by Dr. Wu. This screening is being held by the California Public Health Department, and it's going to go over certain regulations, California's regulations specifically to children lead screening, the role of anticipatory guidance, risk factors, clinical effects, and management of childhood lead exposure, and appropriate health and environmental interventions. We do have the link registered, or the link for you on the screen. If you would like the link emailed to you, please let us know, and we'll make sure to get that over. It's really important. We highly encourage that you attend this screening. So now we'll move on to the retired measures. There's only 2, so this is going to be a very brief section. So the first measure that we have that's retired is the Body Mass Index, or BMI, assessment for adults, which, as you know, is a programmatic measure for this year. And we have the Member Satisfaction Surveys, which is an exploratory measure this year. So the BMI measure was discontinued by NCQA, but it is still very important to collect the height and weight and calculate the BMI on adults. So these 2 measures will not retire until December 31st of this year. So please continue to perform the BMI assessment for adults until the end of this year. These will not fall off of the program until January 1st. All right, so we're going to wrap up today's presentation with some resources that we have available to you. And first and foremost, I'm going to start by talking about the provider portal. And my hope is that most of you on the phone today are familiar with the provider portal. I know that if you've had a CBI forensic visit with us, I know we have pushed the portal. Kristen also mentioned the portal during her part of the presentation today. If you are not familiar and would like additional training, I highly recommend you to reach out to your provider relations representative to schedule a training for either yourself or your entire office. There are a few new items and updates that we've made to the portal this year. So first, we've added new quality reports that align with the new measures that we added for 2020. And this also includes a new report feature, which I will go over more in detail on the next slide. We've also updated your CBI reports for 2020. Of course, we'll do the same for 2022. And lastly, the diabetes care report, which you can find in the quality report section, has been updated to reflect the changes that we've made for 2020. So for those of you who have been with us for a while in the CBI program, might remember that we used to look at good control for diabetes. Now we're testing or measuring poor control. I want to talk to you about the importance of looking at the summary above each report when you're looking at a quality report. It's very important to read through the summary. I know some of them can actually be pretty long, but we do make updates, and this is one of those reports where we did update the text. More updates will be coming soon, so be on the lookout for those. This is a look at the new report feature that I mentioned in the previous slide. This is on the quality report. So as each new quality report comes out, we will make sure to add this feature. Based on the quality reporting metrics, this feature allows providers to see their performance compared to the 25th, 50th, and the 75th percentile. So it really gives you an idea of how well you're performing in the quality measures. So next we'll go over the data submission tool updates. So we've made quite a few updates this year. We have added some new measure types. Those align more of what our program looks like for 2020. So I'm not going to read through the slide. I'm just going to give you a few. Chlamydia screening for women, bilateral mastectomies, and fluoride varnish, which we discussed earlier today. We have discontinued 2 measure types because we're no longer tracking those in the CBI program. So those include the depression screening and the diabetic retinal exam. And as a reminder, we do only accept CSV files. We are no longer accepting text files. So if you submit a file through the data submission tool and you receive a rejection, a lot of times that's the reason, because we get them in either text or Excel. There are 2 of us here at the Alliance, now only one for just a few months. That's myself. So if I actually get a copy of the submissions that you submit every day to see if it was rejected or accepted. Please rest assured that if there is an issue, I will reach out, especially if I start noticing a pattern of rejection reasons. I'll reach out to work with you on how to submit that for acceptance for CBI. So the next two slides look very similar, but they're actually a look at a timeline. So we started with the data submission tool in 2017. We only had one test type, that was the A1C results. And now we have expanded to several test types. So each year as we continue to grow in our CBI program, we will continue to add new measure types. So I'm just going to mention a few. We have immunizations. We are accepting hysterectomy codes. And of course, those IHAs, especially if you're trying the 3 attempts. I know right now there are a lot of providers struggling with that. So as a reminder, if you try the 3 attempts, the member doesn't call you back or schedule their appointment, then you can submit that through the data submission tool. The data submission tool is a source for those of you unfamiliar with the tool. It's a source to upload your data to capture services rendered that were not billed or on a claim. So some new test types, they're indicated with the teal that says new. It's about the last 4 on the screen. We actually did add controlling blood pressure, I believe last year or earlier this year, but we've added well child visits 0 to 15 months, chlamydia screening, bilateral mastectomies, and fluoride varnish. We do have a data submission tool guide located within the provider portal for either in view format or download format. I know a lot of people like to download. I know that I have a copy as well on my desktop for reference. One of the neat things that we did add to the guide is that we added a section, it's actually an entire page, where if you click on we actually have the format already for you. All you have to do is download the report and add your data. One of the other things I wanted to mention about the data submission tool is that we have updated or will be very, very shortly updating the landing page. So when you're getting ready to submit a file, please, please, please make sure that you check either standard or non-standard supplemental data. There is a difference. So we've updated the guide, which will be released soon as the changes are rolled out. So please be on the lookout for that. For standard, it's being pulled from your EMR. For non-standard, you're entering the data. So I just wanted to make sure that I mentioned that today. The deadline to submit your data for 2020 is February 28th, 2021. So I can't believe we're almost to 2021. So if you have any data that you have not submitted yet for CBI year 2020, you have until the end of February. After that date, I'm sorry, we will no longer be accepting that. We are also asked a lot of the frequency in which providers should submit their data through the data submission tool. And really, this is just subject to whatever works best for the workflow in your clinic. However, I can tell you our best suggestion would be to submit either monthly or quarterly, and that way you have the ability to track your progress. Okay, so we have a lot of resources available. I'm going to start with the provider webpage. So we have a lot of information on the provider webpage, but since we're talking about CBI today, I just want to point out that we have a provider incentive page. Within that page, we have an incentive summary, which is a short 8-page summary on our whole CBI program. This is something that I typically like to print out. I have it at my desk. In case you need to quickly reference something, this is a very condensed version of the technical specifications. We have tip sheets. So you do have a copy of the tip sheets in your workbook that you received, but those are also available on the provider webpage. We have toolkits and benchmarks. And lastly, we have recorded trainings. So this training will eventually be on the webinar section of the provider webpage. One other thing that I wanted to mention is on the provider webpage under clinical resources, you will find a quality improvement section. We are currently in the process of creating and developing Practice Transformation Academy videos. So once those start rolling out, we will be placing those videos there. They're just quick snippets of using quality tools within your office. So we started with SMART goals, we're working on project charters, and then we'll be going on from there. So we were able to have a Practice Transformation Academy in Merced, but due to the current circumstances of what our world is currently in, we were unable to provide that for Monterey and Santa Cruz this year. So we still wanted to provide our providers with the ability to see or have quality tools at their hands. Next, we have the provider portal, which I did talk a lot about, so I'm not going to go much into detail with that. We have a lot of reports available. Specific to CBI, we have a dashboard, so you can track your progress. You can create the dashboard and which metrics you'd like to follow your progress. We have a forensic report, and of course, quality and the data submission. If you would like a training, please reach out to your rep who will get you in contact with the portal specialist. Next, we have the quality improvement and population health team. We do offer practice coaching and CBI forensic visits. Currently, those forensic visits are virtual, so you won't have us come into your clinic just yet, but we still want to provide you an update on your trending data. And then last but certainly not least, we have a care management page that has a lot of resources as well, including a virtual or online referral form. All right, so some key takeaways and points from today's visit, specific actually to my section. Please take a look at our incentive page online. We do have a really awesome incentive summary. We have someone who works really hard on that, and she's just amazing. She's very meticulous, so please make sure to look at that. Obviously, our new tip sheets. If you're interested in scheduling a CBI forensic visit to review your trending data or your CBI performance, please let us know. And if you're curious about practice coaching or you'd like some more details, please let us know. We have provided the email for you on the screen, pc@cch-alliance.org. So one of us from the practice coaching team will reach out to you once you email us.
Wonderful. Thank you, Sarah. We've received several questions this afternoon and can now begin answering them. Please continue to submit questions you have via the questions pane. And if we're not able to get to everything today, we will address them when we send out the recording of today's webinar. Our first question will go to Kristen, and that is, will there be any changes to CBI this year due to COVID? And by this year, I'm going to assume that's 2020.
Thanks, Joe. So that's a really great question. It's certainly something that's been on our minds and something that we've been tracking as we've been watching different policies that go out, as well as changes from the state in terms of expectations. So we have discussed this, and proposed changes have been brought to our physician advisory group in September. And specifically, there were two different things that we proposed to them for CBI 2020 for changes. So one of the things that I talked about today was the change to include telehealth. So specific to well child visits, this is something where we are modifying our methods so that we can pull in telehealth visits for well child visits. So that will be one implementation change to CBI 2020. The other proposal that we discussed during the physician advisory group were other policy changes that we saw through DHCS. So in response to the public health emergency, DHCS has released a number of different changes in their guidelines for policies, and specific to initial health assessments, we do want to align with their policy release that happened this summer. And so they are having a temporary suspension for the requirement to be completed within 120 days. And so our recommendation to the physician advisory group was to have this looked at so that if you were eligible for the measure and you had those 5 people in your population, you will receive full points for the measure. The other thing with that is IHA is a measure that's a part of the performance improvement measure, and so the methodology for that will still be the same. So you will still be rated on the rate that you receive for IHA to see whether or not you receive that performance improvement points. And so that's met by either making an improvement in the measure by 5 percentage points or by reaching the plan goal. So it's the same methodology that's in the contract and our technical spec.
Awesome. Thank you, Kristen. Much appreciated. All right, we had a question come in about TB risk assessment. So this would likely go to Sarah since you addressed tuberculosis. How is TB risk assessment tracked? Some background, we have a risk assessment built into preventative exams, but aren't reporting it to the Alliance. Is there a CPT code we should be adding, or is the diagnosis Z11.1 enough for you to capture this?
That's a really great question. Thank you for whoever asked that. I don't believe for this measure that we put the coding on the actual screen. So Joe, will you table that and I will get back to that person?
Absolutely. Absolutely.
Joe, I can actually pick up this question. Okay. We do have the coding. So on the slides, we had the diagnosis code. So we took a look at this measure, and the CPT codes that would be involved would be for that test. So instead for this measure, we are looking at the diagnosis code. So the one that was on that screen on your slide, that will be what we will be looking for. And I do think that there's a note about not having that as a primary diagnosis code, but that would be something that we'd have to get back to you on. But there will be no CPT code, just the diagnosis code.
Awesome, thank you. Let's see, and then now for alcohol screening. Does the alcohol screening have to be a full screening? For example, the audit C, or are the questions, if answered on the SHA form, enough to qualify as performed?
So that's a good question. So the SHA is kind of different in the sense that there's the single alcohol questions that they have on there for members that are 18 years and older, and then they have different SHA questions for the other age populations, since all of their SHA forms are based on age. So there's 4 questions that are in the 12 to 17-year-old form and 2 questions that are on the 9 to 11. We will take that. It is the industry standard to use either the audit or the audit C, which is an abbreviated form of the full audit questions. So either one would be accepted.
Wonderful, thank you. Thank you. All right, so next question, how will the Alliance compensate for members who do not want to have an on-site visit due to COVID? Even some background, even with encouragement, patients are reluctant and we can't force them to come in. This may be a question kind of also, will there be any changes to CBI this year due to COVID? Those 2 questions came in, so they seem like they could go together. I pass that to Kristen, or if anyone else wants to grab that.
Sure, I can take that, Joe. In terms of changes, we do expect there to be an overall drop in rate. So this is something that Dr. Diallo brought up, is we've seen just about around April in our rates, there's been a drop in immunizations, there's been a drop in well care, we're noticing some other drops. There isn't anything planned outside of the 2 different changes that I mentioned earlier. So in terms of CBI 2020, we are expecting there to be a reduced rate in all of the measures for all of our providers. Certainly, this is something that if we do need to bring it up to the board, we can. So for example, the overall payment that we have for CBI is approved by our board in December. So if there are any additional concerns, they can be brought up then. But our expectation is that with the pandemic, overall rates are going to be kind of across the board lower. And since you are rated also by your peer group for your payment, it should about even out for all providers since everyone's rates are going to be lower during the pandemic.
Awesome, thank you. And kind of on to that same note, a question came in. Do voice-only phone calls count as synchronous telehealth visits?
Yes. And you would just need to make
Perfect.
sure to use either the telehealth, the modifier is going to note that synchronous one version, but if you also are billing with the 1500 form, you would use the point of service code as well, the 02.
Awesome, thank you. And it looks like last one in the vein of telemedicine. More questions are coming in. How will the, nope, wrong one, so sorry. There we go. In the past, CHDP did not allow clinics to do WCC via telemedicine. Has this changed? And does the billing I'm so sorry, does the billing loss or does the ICD-10 code let the Alliance know that we did a WCC visit via telemedicine?
So this is something, Joe, I'm going to have to ask if the person who submitted the question could let us know which ICD-10 they're talking about. I'm assuming it's, when they say WCV, that's for well child visits, because it will look for a visit either by the CPT code or the ICD-10 with the PCP or an OBGYN. In the cases of billing, we are still looking for the telehealth code to be attached. I haven't heard anything specific to CHDP changing their guidelines. But NCQA is allowing for the telehealth visits.
Great, thank you. Thank you. All right. And another question, we have used PPD in the past. Should we use PPD? Will you only be counting quantiferon, and how will you count PPD readings? I'm not sure if that question should go to Dr. Diallo or.
I don't know of any changes in not accepting a PPD. As far as what the codes that will be looked for, Kristen, do you know about the codes that will be looked for?
So this goes back to the risk assessment. So it will be that diagnosis code that we're looking for. So the quantiferon is a test, which would be a CPT, but we're not looking, in this case, we are just looking for the risk assessment to be done. And then at that point, we would be looking for the diagnosis code for the risk assessment for the screening.
Okay, so therefore, what test you use is up to the provider, essentially.
Correct.
Awesome, thank you. All right, looks like I have two more questions. Next one is regarding alcohol screening. The tip sheet states that patients 18 and over should be counseled if engaged in risky behavior. Since the measure is asking to screen ages 11 and up, should we also be counseling and using code G0443 for ages 11 to 17 if behavior is considered risky?
So that's a good question. You should definitely be counseling them if they do screen positive for unhealthy alcohol use. The only issue is when we were taking a look at the codes, there isn't anything to note the counseling aspect right now through Medi-Cal codes. So what we would be looking for the younger age range is first the screening to come in through the G0442 code, but the counseling, we don't actually accept any codes at present that would be paid out as a benefit. So if you were to submit the G0443, it would be denied because the age restrictions start that code at 18.
Wonderful. Wonderful. Thank you so much. Final question, and it looks like one that I can probably address as well. And it's for the Childhood Immunization, or CIS Combo 10 quality report. There's noticing that there are no dates population for the polio or PCV vaccine. And that is true for both patients listed as compliant and non-compliant. We are currently looking into this, and we hope to have that fixed within the next monthly cycle of that report. So thank you for making a note of that. It has been brought to our attention, and we are working on a fix for that. So thank you so much. I'll leave just another second for any final questions to come in, but that does wrap up the questions that we've received thus far. And if any questions come up for you after we end today's webinar here momentarily, please contact your provider relationships representative, or as you see on your screen here in front of you, our CBI contact information is the CBI email, Kristen's information, and Sarah's as well. Following today's webinar, you will receive a survey. Please take a few moments to fill that out and provide your feedback. We find constructive criticism very helpful, so please let us know how we're doing. You will also receive a follow-up email with a link to view today's recording. And as previously mentioned, we will write out and answer the questions that came up today. So again, any follow-up questions, specific coding, anything like that you guys have questions on, please feel free to email Kristen, Sarah, or your provider representative. All right, I don't see any other questions coming through, so it looks like we can end a little bit early today. On behalf of Central California Alliance for Health and our presenters, thank you for joining us. Have a great rest of your day. Goodbye.